The first topic to discuss in cardiac pathology is ischemic heart disease. Ischemic heart disease is a group of related syndromes due to imbalance between myocardial oxygen demand and supply from the coronary arteries. What will happen as a result of this that the myocardium is not getting enough oxygen, there is inadequate nutrient supply, and there will be diminished metabolite removal. One thing to remember is that myocardium exclusively depends on oxygen for its ATP generation function. So it does to some extent do anaerobic respiration as well, such as other skeletal muscles, but that is very inefficient and it can only sustain the muscle for a very short time. So whenever we have occlusion of an artery that causes ischemia, we should time is money in this case. So whatever you do, you should get the patient to the hospital and try to reperfuse that part of the heart as soon as possible, or it will die and well, then it's gone forever. Now, why does ischemic heart disease occur? Why does ischemia occur in the first place? There are 4 reasons for that. There can be decreased coronary blood flow, increased myocardial demand, diminished oxygenation of the blood, or diminished oxygen carrying capacity of the blood. First of all, why does decreased coronary blood flow occur? The chief and major culprit for this is atherosclerosis. Of course, I've discussed this in a previous video. You can check that. And vasospasm is another culprit, and thrombosis due to atherosclerosis is another factor. Other uncommon causes of decreasing the coronary blood flow are arteritis, which is artery inflammation, emboli, and hypotension, such as that occurs in shock. The second reason is increased myocardial demand that can occur due to tachycardia and also due to hypertrophy of the cardiac muscle. This can occur due to congestive heart failure, when the heart fails to pump blood and the muscle of the heart tries to compensate for that and undergoes hypertrophy. So the more muscle, the more demand. And thirdly, we have diminished oxygenation that can occur due to any intrinsic lung disease such as pneumonia, and also due to congestive heart failure, when the right side of the heart fails to pump blood into the lung for oxygenation, or the left side fails to pump it forward. And also we have diminished oxygen carrying capacity that will be in the circumstances when we have anemia or carbon monoxide poisoning that will diminish the capacity of the blood to carry oxygen. Now, the risk factors for ischemic heart disease are similar to those of atherosclerosis because this is the major culprit, and the incidence for IHD increases with age. It usually affects men more, and postmenopausal women, that is more than 55 years of age, women are also prone to develop IHD because estrogen is thought to be cardioprotective. Regarding the pathogenesis, as we have discussed already, that it is the result of inadequate coronary perfusion relative to myocardial demand. So either the perfusion is low or the myocardial demand is too high. And this usually occurs in the presence of pre-existing atherosclerosis, vasospasm, and thrombosis. The 3 arteries which are mainly affected are left anterior descending, LAD, left circumflex, and right coronary artery, and sometimes it occurs in secondary branches too. We'll discuss this later in detail. Now, here are a few terms to know. First, we have critical stenosis, fixed stenosis, and collateral perfusion. Critical stenosis means that when an artery is more than 70% occluded, the lumen of the artery is more than 70% occluded, that means we have critical stenosis, and this will result in stable angina. That simply means that the chest pain that you'll have will only be present when there is exertion or exercise, that is when the myocardial tissue has increased demand. Okay, while fixed stenosis means when there is greater than 90% occlusion of the coronary artery, and in this case there will be chest pain at rest as well. Collateral perfusion means that if the atherosclerotic lesion progressively occludes at a slow rate over a long period of time, then the cardiac tissue gets enough time to remodel and compensate the blood flow and develop new arteries and collateral roots. So what will happen is that this is actually protective against MI, and the same part of the tissue which was not supplied by a slowly occluding artery will be supplied by other branches. Now, there are some elements that contribute to the development of IHD. First of all, we have inflammation. Atherosclerosis itself is an inflammatory process, and if thrombosis occurs in association with the inflammatory plaque, then we have acute coronary syndrome. Vasoconstriction can be stimulated by many factors, such as circulating adrenergic agonists, such as norepinephrine, epinephrine, locally released platelet contents, imbalance between endothelial cell relaxing factors and contracting factors, and mediators released from perivascular inflammatory cells. So all these factors will increase the risk for developing acute plaque change. Okay? Now, what is acute plaque change? Mostly, unstable angina, MI, and sudden cardiac death occur due to abrupt plaque change followed by thrombosis. Now, there are many mechanisms by which this can occur. The plaque can rupture, it can fissure, it can ulcerate, and all of these three processes are going to expose thrombogenic plaque contents. So, if this is the plaque, it undergoes fissuring or a rupture or ulceration. What will happen is that all of these cases will expose a thrombogenic surface, and thrombosis will occur immediately and acutely and block this whole vessel. That is called acute plaque change. And hemorrhage into the plaque, that for some reason this plaque fissures or ruptures, and due to high blood pressure, blood starts flowing through the plaque, that will enlarge the plaque and cause occlusion of the vessel. Now, there are some factors which affect plaque stability. So those plaques which have a large atheromatous core and a thin fibrous cap are more likely to get ruptured. Okay, and conversely, if the fibrous cap is more thick and the atheromatous core is small, then there is less chance of it getting ruptured. The other factor that will affect plaque stability is extrinsic influences, that is adrenergic stress. So one thing to remember is that most MIs occur early in the morning, between 6 a.m. to 12. So that simply means that when we wake up, we have this adrenergic surge, and that is partly responsible for disrupting that plaque. And emotional stress due to environmental disasters, etc., is also a factor. Now let's read this. Plaque disruption and resulting non-occlusive thrombosis are common, repetitive, and often clinically silent complications of atheromas. So sometimes the plaque may rupture and the thrombosis may be non-occlusive and thus then simply dislodge and cause no clinically evident symptoms. Now finally we'll come to the classification of IHDs. First of all, we have angina pectoris. This is simply intermittent chest pain caused by transient reversible myocardial ischemia. This is reversible, just remember this word. So this chest pain of course we know that occurs due to some mediators, and in this case we have bradykinins and adenosine. There are many types of angina. We have stable angina, unstable angina, and Prinzmetal angina. Stable angina occurs when we have greater than 70% atherosclerotic stenosis, and this only occurs with stress and exertion when the myocardial demand of oxygen increases. This injury to myocytes is reversible, and one thing to remember is ST segment depression, because it causes subendocardial ischemia. I will come to this point in the next slide. You'll understand this. But the clinical symptoms, we have chest pain, sweating, and shortness of breath, and it can be relieved by nitroglycerin. Every form of angina can be relieved by nitroglycerin. Secondly, we have unstable angina, which is plaque rupture plus incomplete occlusion of a coronary artery. This is also a reversible injury, and this also causes ST segment depression because we have subendocardial ischemia. I'll explain this. But unstable angina has a greater risk of progression to MI because we firstly discussed that unstable plaque is when we have greater than 90% occlusion, and this has a great risk to develop to MI. Lastly, we have Prinzmetal angina, which occurs due to vasospasm, and this spasm can occur due to emotional distress or also due to drug abuse such as cocaine use, etc. This is also reversible injury, but in this case we have ST elevation, and I'll explain that in a while on the ECG. Next we have myocardial infarction. Infarction means death of the tissue. So what happens is that in this case we have necrosis of the cardiac myocytes resulting from ischemia. So the damage is so large and evident that we have necrosis of the cardiac myocytes. So why does the ischemia occur? Just as we have discussed previously, due to rupture of an atherosclerotic plaque with thrombosis and complete occlusion of a coronary artery. So you can see that we had incomplete occlusion here and then complete occlusion here. It can also be due to vasospasm, emboli, and vasculitis. Now in this case what happens is that we have severe crushing chest pain, diaphoresis means sweating and shortness of breath, and nitroglycerin in this case cannot relieve the pain. Now coming to the arteries that are commonly affected by MI, we have left anterior descending, which is 45% of the cases this artery is involved, left circumflex coronary artery, and right coronary artery. So in this case we can see that if this artery is occluded, infarction of the anterior wall and anterior septum of left ventricle will be there, this portion. And if left circumflex coronary artery is occluded, we'll have lateral wall of left ventricle infarction. And if the right coronary artery is occluded, we're going to have infarction of posterior wall, posterior septum, and papillary muscles of left ventricle. Now let's see some ECG changes in different types of myocardial infarctions and angina. So basically there are three patterns of infarction or ischemia. First of all, we have transmural infarction. Transmural infarction means that the whole of the wall of the ventricle has undergone ischemia or infarction. That depends. And what happens is that we know that the heart muscle is supplied by an epicardial vessel which goes like this inside, and this part, this endocardium, is supplied by the blood which is within the heart chamber. So if you occlude a vessel, an epicardial vessel, the most vulnerable part of the whole heart muscle will be this subendocardial region. Okay, so in this case what happens is that in this case epicardial vessel will be fully occluded. If it is fully occluded, then neither this part will be supplied nor this one. The whole of the ventricle will undergo uniform necrosis. It will have ST elevation, and it is called ST elevated myocardial infarction. I will explain this in the curve below. Secondly, we have subendocardial infarction. Subendocardial infarction means that only this area has undergone infarction, because this is the most vulnerable area. Okay, and this is called non-ST elevated MI, and this will have ST depression. I'll explain this. And lastly, we have microscopic infarcts. This simply means that the whole of the ventricle or the whole of the heart has small areas of infarctions, because it has small vessels which have occluded. This chiefly occurs due to vasculitis, embolization of valve vegetations or mural thrombi, and vessel spasm due to catecholamines or cocaine or stress. In microscopic infarcts, we do not have any diagnostic ECG changes that can show us the detail of this disease. But in case of transmural infarction and subendocardial infarction, we have ST elevation for this case and ST depression. Now I'll explain why this happens. So I want you to remember that when I say transmural infarction, that means MI, and when I say transmural ischemia, that means angina. But the ECG changes are the same. Now forget about everything and just look at this curve. We know that this is a normal action potential of a cardiac myocyte. The resting membrane potential is minus 90 millivolts. Now we know that this minus 90 millivolts is attained due to the fact that we have sodium channels, potassium channels, calcium channels, and many other as well, but these three important ones are going to play a role here. So we know that normally sodium ions are in higher concentration. Sodium ions are in higher concentration outside the cell, and potassium are high inside the cell. Sodium channels, there are no sodium channels that allow leakage inside the cell, but there are some which allow potassium leakage even at resting membrane potential, but that is not important. What's important is that we always have a gradient for sodium and we have a gradient for potassium. sodium always wants to come inside and potassium always wants to go outside because of the concentration difference. And because of this, we have this resting membrane potential, which is minus 90 millivolts. And at this potential difference, we have sodium channels which are closed. Okay, and this membrane is ready to get depolarized. Now, with that in mind, let's see that if this cell is somehow damaged, if it is damaged, it will have no ATP. It is undergoing ischemia, hypoxia, no oxygen, no ATP. So we have specialized channels for potassium which are closed normally because of ATP. If there is no ATP, these channels are going to open and they will allow potassium to go outside. Now let's imagine this again. So if we have lost potassium to the outside of the cell, and say if we had this concentration difference before, we have this amount of concentration difference now. So potassium would still want to go out, but not as much as it wanted to before. You understand that? So if the concentration difference, the difference has decreased, that means this membrane, which was more negative, now is less negative and more positive. That means that is because more positive charge has gotten out of the cell. Okay, so if this is more positive now, what will happen is that we know that at minus 90 millivolts, the sodium channels are likely to be excited. If the membrane potential goes more positive, they are not ready to be excited anymore or open. So what happens is that this spike which is normally present due to the sodium channels is not going to be there, and this plateau was due to calcium influx, slow calcium influx. So now this current is only going to be due to slow calcium channel opening. Okay, so in the damaged myocardial cell, we have this action potential. Now you can see the difference between this and this. Okay, now with that in mind, let's see the ECG. So now we know that the resting membrane potential in the damaged myocardial cell or the ischemic myocardial cell is not minus 90 anymore, it is minus 50. It is more positive. So if it is more positive, that means it is already partly depolarized. Okay, so now if it is already partly depolarized, and in ECG or leads, for example, if we take the lead 2, which is placed here towards the apex of the heart, this lead 2 is going to detect the electrical activity that is going towards it. Okay, so we know that in ECG, when there is depolarization towards a lead, there is a positive deflection. Okay, so if this part has undergone ischemia or MI, then we know that it is already partly depolarized. If it is already partly depolarized, this ECG lead is going to pick up that depolarization because it is in the direction of the lead. This isoelectric point, which is 0 millivolts, is going to be raised. Why raised? Because we know that the QRS complex shows ventricular depolarization, right? But in this case, just before the QRS complex, one part of the ventricle is already depolarized. This part is already depolarized. So this ECG lead is going to pick up this electrical activity, and since it is in the direction of lead 2, this is going to give a positive deflection, and this positive deflection is going to raise this wave above 0 millivolts. Okay, so now we have a positive deflection, we have the normal QRS complex in which the whole of the ventricle will get depolarized, this QRS complex, and then we are going to have the repolarization, the T wave. All the other things are going to happen normally. So on ECG, it will look like as if the ST segment has gone down. Okay, so that means we will see ST depression on ECG in case of subendocardial ischemia or MI. Now let's come to the transmural ischemia or MI. Now, since I said that transmural ischemia or MI will cause the whole of the wall to undergo ischemia or MI, now if you see, we do not have depolarization in the direction of the lead. We have depolarization away from the direction of the lead too. So this lead is going to pick up downward deflection. You understand that? So what happens is that in this case, the wave is going to start down. It is going to start lower than it did before. So we saw that we had this downward deflection of this wave, and then we have the normal QRS complex and the normal ST segment. But since we started lower, we think that the ST segment has gone up or elevated. So this is known as ST elevation or ST elevated MI. I hope that is clear. Now let's revise this. In transmural infarction, we are going to have ST elevation, and in subendocardial infarction, we are going to have non-ST elevated MI. Okay? And in microscopic infarcts, we do not have any diagnostic ECG changes. Now I want you to go back into this angina, and here I said subendocardial ischemia, ST segment depression, and in vasospasm, in Prinzmetal angina, we had transmural ischemia because the whole of the artery undergoes vasospasm, right? And the whole of the blood supply is cut off, and thus the whole wall undergoes ischemia. Now, there are some lab tests that help us diagnose MI. We have many molecules which are present normally within the cardiac cells, and when they undergo necrosis, they sort of leak into the blood and then can be detected by blood tests. So these molecules are myoglobin, cardiac troponin T and I, creatine kinase MB, this is specific for myocardium, and lactate dehydrogenase. But of all these, troponin I and CKMB are the most important, and these two are the ones that you need to remember. Troponin I is the most sensitive and specific gold standard for MI, and you can know that you had an MI even 7 to 10 days after you had it. Okay, but CKMB is used to detect reinfarction. Now, to understand that, let's see that troponin I levels rise at 2 to 4 hours, peaks at 24 hours, and then returns to normal by 7 to 10 days. Okay, now this is pretty much the same, but this returns to normal by 72 hours. So I mean to say that if you have an MI at day 1, and in 7 to 10 days, this is troponin I is going to go down, but in 72 hours, CKMB will have gone down. But if you have a reinfarction, then you'll know when the first infarction occurred, right? If you have a second infarction, that means a reinfarction, then you'll again see CKMB. Okay? While you should not see it 72 hours after you had an MI. I hope that makes sense. Now let's see some morphologic changes that we get to see post-MI. Now, less than 4 hours after an infarction, there are no gross or microscopic changes, and the complications can include cardiogenic shock, because the heart might not be able to pump that effectively, CHF, congestive heart failure, because of the same reason, and arrhythmia, as we previously saw how the damaged part of the heart was acting a little funny regarding the action potentials, and thus can elicit some unusual electrical activity and thus contribute to arrhythmias. In 4 to 24 hours after infarction, we can see a dark discoloration in the area that has been infarcted. Microscopically, we'll see coagulative necrosis. That simply means that the structure of the cells will be preserved, but there will be no nuclei. And also the viable cells and the infarcted cells show no clear boundary. The complications include arrhythmias. 1 to 3 days after infarction, the area is going to be yellow and pale due to the inflammation that is going to start, and neutrophils will invade the area microscopically. Now, one complication of this can be fibrinous pericarditis, and chiefly in transmural myocardial infarctions, because when the whole wall is necrosed, what will happen is that when the neutrophils and other inflammatory cells invade this area, the pericardium might get affected as well, and the inflammation may include the whole of the pericardium. This can present as chest pain with friction rub. This is a sound that is produced on auscultation, because both of the layers of the pleura are going to rub against each other. 4 to 7 days, we still have the yellow pillar, and macrophages are going to invade the area. The complications of this stage can be rupture of the ventricular free wall, leading to cardiac tamponade, that is, the blood will build up in the pleural cavity and put pressure on the heart. Interventricular septum may get ruptured, and thus there will be development of a shunt. Or what can happen is that the papillary muscle may get torn, and we'll have problems with mitral valve closing, and it will cause mitral valve insufficiency. 1 to 3 weeks later, we'll have a red border which will emerge between the viable tissue and the infarcted tissue, because the healing is going to start. Fibrosis, because since we know that the heart cells cannot regenerate, the healing is going to occur via scarring or fibrosis. So there will be granulation tissue that will start to enter from the edge of infarct. Microscopically, the granulation tissue will have fibroblasts, collagen, and blood vessels. After months of MI attack, there will be development of a white scar, and microscopically this will be fibrosis. That is the end result of inflammation when there cannot be regeneration. And the complications at this stage can be aneurysm, because the wall has become weakened and it can balloon out. Mural thrombus, because this area might be thrombogenic and cause and pave the way for formation of thrombi. And lastly, we have Dressler syndrome. Remember this. It is actually an immune response to damage to the cardiac muscle. What happens is that it is actually a sort of pericarditis which occurs after MI, and it is due to immune hyperactivity. So the whole pericardium is going to be inflamed. Now, regarding the treatment for MI, we can use aspirin and heparin to limit thrombosis. Supplemental oxygen can be given to save the myocardium. Nitrates for venodilation. Beta blockers to reduce the heart rate and the stress on the heart. AC inhibitors, so we do not have fluid overload. And fibrinolysis or angiopathy, that is, once the clot is formed, the clot needs to be broken down. That can be done by fibrinolytic agents, that is medicines, or by angioplasty. One consequence of restoring blood supply to a part that has undergone ischemia is reperfusion injury. Now, reperfusion injury simply means that if an area of a tissue or an organ is devoid of blood supply for some time, any time, and you go ahead and remove that block and the blood supply is replenished again, what happens is that there are some factors that will contribute to injury to the tissue. So there are multiple mechanisms by which this occurs. Firstly, we can have mitochondrial dysfunction. Now, why is that? Because during ischemia, what happens is that mitochondrial membrane permeability, it gets altered. Okay, so what happens is that the proteins in the mitochondria move out of the mitochondria, and this will lead to swelling and rupture of the membrane, and it will release mitochondrial contents which are pro-apoptotic and thus cause the cell to die. Secondly, myocyte hypercontracture. During ischemia, what happens is that the intracellular calcium level increases and there is impaired calcium cycling and sarcolemmal damage. So after reperfusion, what happens is that there is uncontrolled contraction of these myofibrils, which will cause cytoskeletal damage and thus death of the cell. Another thing is the formation of free radicals. Free radicals such as superoxide anion, hydrogen peroxide, hypochlorous acid, and hydroxyl radicals are also produced, which will damage the membrane proteins and phospholipids. Also, leukocyte aggregation will be there, and it will occlude the microvasculature, that is the small capillary beds, and they also release proteases and elastases, which will cause cell death. And lastly, platelet and complement activation also causes microvascular injury. The third type of ischemic heart disease is sudden cardiac death. This is unexpected death due to cardiac disease, and it occurs without any symptom or less than 1 hour after symptoms arise. So this is what happens is that mainly it is caused by fatal ventricular arrhythmia, which might be predisposed by MIs or other heart problems. The most common etiology is acute ischemia, and 90% of the patients will have pre-existing severe atherosclerosis. Less commonly, the causes can be mitral valve prolapse, cardiomyopathy, and cocaine abuse. So all of this will cause sudden cardiac death. The etiologies are pretty much the same, but the definition is that it is unexpected death, and it will occur without symptoms either or less than 1 hour after symptoms arise. And lastly, we have chronic ischemic heart disease, which is the same thing, but in this case, we'll have chronic ischemia. That is, a part of the heart will be suffering and will have chronically low blood supply. And this can occur with or without infarction, and ultimately it progresses to congestive heart failure, where the heart fails to pump blood. That's all about ischemic heart disease.